Holmium laser enucleation of the prostate is an efficient and effective procedure for the treatment of benign prostatic hypertrophy, especially large glands. The technical aspects of this procedure developed by Gilling and Frendorfer were recently updated by Lingemann and colleagues. One criticism of the procedure has been the difficulty of mastering the enucleation technique. The aim of this video is to update key time-saving enucleation techniques which may shorten operative time and the learning curve. Capturing these techniques on video may help other urologists embrace this successful treatment modality for benign prostatic hypertrophy and potentially improve their operative time and ease of enucleation. This video captures the following time-saving maneuvers that may aid surgical learning and improve operative time. First, one posterior enucleation groove is used rather than two separate grooves, allowing simultaneous resection of a median lobe with an attached lateral lobe. Second, enucleation is started with the prostatic apex lateral to the verumentanum rather than anteriorly at the 12 o'clock position. Third, the apical enucleation is carried past and deep to the anterior median sulcus, thus providing a dissection target for the 12 o'clock cut. Lastly, the tethering mucosal bridge at the prostatic apex is retracted and incised using an encircling technique which speeds resection and prevents harm to the external sphincter. Posterior enucleation with a single groove saves time by enucleating the median lobe with the associated lateral lobe, preventing the need for a second groove. In addition, a good plane can be carried through the median lobe to the associated lateral lobe, preventing diverging planes of enucleation. This video demonstrates a single incision at the 7 o'clock position between the right lobe and median lobe. This is carried through the prostatic adenoma and down to the capsule. Circular fibers of the bladder neck are identified and preserved. The groove is advanced distally and widened using the beak of the scope. After the right lobe is enucleated, the left lobe and attached median lobe are easily enucleated together. The left gland enucleation proceeds in the usual fashion after the median lobe mucosa is freed from the verumentanum mucosa distally. This technique helps avoid the need for a second enucleation groove and can prevent diverging enucleation planes from developing. Historically, prostatic apex enucleation has started at the 12 o'clock position, with enucleation proceeding laterally and downward. This anterior to posterior process of enucleation at the apex can be associated with difficulty defining planes and poor leverage of the prostatic apex. When starting the enucleation posteriorly and developing the enucleation lateral to anteriorly, gravity aids the resection by providing leverage. In addition, the apex is easier to manipulate while the rest of the gland is fixed to the fossa, and posterior gland capsule planes are better defined. The technical aspects of this procedure, as demonstrated in the video, are as follows. The scope is placed at the ridge between the lateral lobe prostatic apex and posterior floor, proximal to the external sphincter. The mucosa is incised lateral to the verumentanum, and the underlying gland is rolled to expose the gland capsule plane. The enucleation is then carried laterally and rotated anteriorly to include and encircle the apical glandular tissue. This, in essence, gives the enucleation a solid starting point that can be referenced during the rest of the enucleation. Once the enucleation is carried completely around the glandular apex, the enucleation is continued anteriorly toward the contralateral lobe and past the midline deep to the anterior sulcus. This maneuver provides a space or cavity to enter during the 12 o'clock incision, thus preventing the development of a second dissection plane with a fresh anterior or 12 o'clock incision. In addition, the maneuver carries a good enucleating plane to the opposite lobe, which will promote an easier resection of the second lobe. Once the mucosa of the apex has been incised in the midline anteriorly and posterolaterally, the underlying glandular tissue is enucleated. Afterward, a thin swath of mucosa tethers the gland near the external sphincter. This mucosa is the uncut mucosal remnant left over from the apical enucleation. Resection of this tissue is complicated by its relation to the sphincter and the degree of its tethering. Wasted time accumulates rapidly if this tissue cannot be incised efficiently. The best technique to capture, secure, and bring the mucosa away from the sphincter is the encircling technique. This is accomplished by starting in the midline and bringing the scope above and around the partially enucleated gland. First, starting anteriorly, the scope is moved laterally, then posteriorly, and finally back to midline. Once in the midline, the laser fiber is placed at the 6 o'clock position and the rate turned down to 20 Hz. The mucosal swath is not yet seen, but is felt or sensed as a resistance on the scope. Slowly, the scope is pulled back into the urethra until the mucosa is seen in the midline of the fossa, near the laser fiber, and away from the sphincter. The mucosa is then cut, releasing the tethered apex of the partially enucleated gland. Of note, this should be completed prior to finishing the lateral bladder neck and posterior floor enucleation. We hope reviewing the 4 techniques of 1 posterior groove, posterior apical enucleation, anterior apical advancement, and the encircling technique will improve operative times and shorten the learning curve for urologists performing the HOLEP procedure.